Okay. Hello, good evening, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. We are coming to you live from Kuala Lumpur, and our production is with Dr. Apajita in New Delhi in India. I'm joined by fellow senseis, Chris Cuddy in Sheffield and Prof. Sile in the Kingdom of Brunei. Thanks to iEcho, we are reaching 23 countries across the globe, and our numbers are increasing. But that will only increase further if you make recommendations, and it will only grow by word of mouth. I'm delighted to report that we had our second grading on Saturday, and we have now got 7 red belts, 7 yellow belts, and 4 red belts who have started their journey of mastery of basic surgical skills. It is really heartwarming to see the enthusiasm, but it's also a pleasure to now see that they appreciate the feel of the instruments. To get accreditation for the face-to-face, I've submitted documents to the Royal College of Surgeons of Edinburgh, and they're going to be reviewed by no less than the Vice President, Professor Angus Watson, OBE, who already has extolled the virtues of the Black Belt Academy of Surgical Skills. So fingers crossed. But the face-to-face delivery is actually raising a lot more learning and creating opportunities for further research in education and the development of surgical skills. As you know, this is not a one-off lesson, but a transformative longitudinal process of mastering basic surgical skills. And in that regard, I've always drawn my lessons from martial arts that I've been doing now for 11 years. And what I'm still practicing is the art of drawing the sword. And I bring the sword up this evening because the katana, as you can see, is curved, and this curve is actually called a sori. And the curve is not entirely artificial because the blade is made of a soft metal wrapped over a hard metal. During the quenching process, the softer spine contracts less than the harder, thinner edge, pulling the blade, as you can see it, into a curve. This sori facilitates the slicing motion, and the whole of the blade should be used as a slice. And it's the left hand that directs the force and stops it, but it's the right hand that carries the angles. The draw of the sword is facilitated by the fact it's curved, and it allows for an efficient one-handed use, which is essential for a samurai on horseback. The fact that it's curved also means as you cut, it doesn't bounce off. In fact, it reduces the target, reduces the bouncing off of a target compared to a sliced, a straight blade. And it enables the cut to align itself on impact. The balance of the sword is also changed by the curve as the center of gravity is brought closer to the handle, improving handling, maneuverability, and reducing the perceived weight. Now, this is a custom-made Iaito. It's not a full sharp blade, but it is otherwise produced very much like a katana. So the weapon itself is directed to maximize cutting efficiency during drawing and slashing motions, particularly on horseback. And the shape allows for the smooth, faster, stronger action because it uses the natural cutting arc of the blade. And therefore, the practitioner needs to know the anatomy of the blade. So what we have here is the point, or the kasaki, and that is maintained at the direction of the throat of the opponent, maintaining your junction and focus. The end bit here, the boshi, is a curved, which combined with the minuki in the first 10 centimeters is the minuchi of the blade, and that's where the slicing happens. The edge itself is called the ha, and the groove, the blood groove, is the hi, and the mune is the back of this. And the solid ridge of this, which is used for blocking blows from other weapons, is called the shinugi. The hibachi holds the blade in the saya and is protected from the suba, the handle, by the suba, and it protects this handle, which is effectively made of two pieces of bamboo held, wrapped around with silk or cotton in this case, and really held together by two little pegs of bamboo or manuki that have gone through. The bottom of this, the kasura, is likewise a weapon for hitting and stabbing. It's important to know the anatomy of the blade because it actually enables you to understand its function and use, particularly when you're drawing and striking. I go training every Sunday, and every Sunday proves to be another lesson. What was interesting in my drawing, I note that there's a forefinger and middle finger draw of the saya, which I hadn't appreciated previously. And we'll come back to that when we talk about knot tying at a further event. Pop this down. Katanas, actually, the original katanas, are priceless. And the sang, which is the metal bit that's held between the two bamboo handles, is often signed by the forger. And the tempering mark is the pattern of the clay that is used to give the temper and pattern of the sharpened edge. Well, the history of the surgical needle mirrors the evolution of surgery itself, from ritualistic care to precise technology and enhanced operative practice. Archaeological evidence shows that as early as 30,000 BC, prehistoric humans sharpened implements like bone splinters and thorns to approximate wounds. But the first form of sewing was probably tying together of animal skins using thorns or sharpened rocks as needles, and animal sinew or plant material as thread. And the earliest limitation was the ability to produce a hole small enough in the needle matrix, such as bone and silver, not to damage the material, but also to make the hole small enough and the eye small enough that itself didn't damage the material it was being drawn through. A point that might have been made from a bone needle dates back to 61,000 years ago in the Sibudu cave in South Africa, and a needle made from bird bone attributed to archaic humans was found in the Denisova caves 50,000 years ago. A bone needle also found in the Potok cavern in eastern Slovenia 41,000 years ago. And bone and ivory needles are found in prehistoric caverns in the Liaoning province between 30,000 and 20,000 years ago. So they've been around everywhere for a long time, and even found in the Kotensky cavern in Russia 30,000 years ago. But it's the ancient Egyptians and Indian medical texts that describe the suturing with linen, plant fibers, and animal sinew, and indeed also found in the tradition of Sushruta around 600 BC. All sorts of needles are described, from metal to organic materials. But the metalwork was really refined by the Romans, producing bronze and iron needles with drilled eyes, similar to the very sewing needles that we see today, through which a thread is passed. Those early eyed needles required surgeons to manually thread the suture. But because the eye was bigger than the body of the suture and you had a double layer of thread, you can imagine this was causing quite a lot of damage to the tissues themselves. Now, during the medieval period of the Islamic Golden Age, scholars such as al-Shawari, in his epitome, the Al-Tarif, actually depicted curved needles. And I found this astonishing when I read this, because I was trying to figure out where and when we actually got curved needles. Because if you think about it, there is a straight needle in a cup. And I cannot take this needle, here we go, on straight, and I cannot maneuver it in a cup. So it's therefore logical, a wonderful logic, to take a curved needle, and I can now use it and manipulate it at depth, as in the bottom of this cup. Who actually thought of that? I don't know, but it's interesting to know that al-Shawari has got pictures of it. By the Renaissance, European surgeons were adopting increasingly specialized needles shaped to accommodate deeper wounds and more delicate tissues. Indeed, the earliest needles, as we said, were copper or bronze, but it was only until the 14th century that Hayward records that Cistercian monks in Bordesley Abbey near Redditch in Worcestershire converted drawn steel wire into iron needles, and that forms the basis of manufacture today. And in about 1655, needle manufacturers were sufficiently independent to establish a guild of needle makers in no less than Threadneedle Street in London. And through that, Redditch became the principal centre of manufacture of sewing needles as we know today. But the types of needles and points were described back in 1497 by Brunswick and 1575 by Paré, who introduced three-cornered, trocar-pointed, straight and curved needles and evidenced a grooved eye to reduce the bulk of the thread and reduce the trauma of the swage at the end. It was de Mondeville in 1320 who remarked that the suture wounds inside the mouth and eyelids required a curved needle, and a crooked needle was the best thing to use. But it was really the advent and improvement of metallurgy and aseptic techniques that the demand for surgical needles rapidly increased and continues to this day. And it's amazing the diversity and the sizes and shapes. And by 1961, that enabled Shrimpton to offer 5,000 different needles for purchase. So the Industrial Revolution really made a turning point in the manufacture of stronger, finer, and more uniform needles. The curvature, as in the story of the blade, then with increasing manufacturing became standardized. So we had a quarter curvature, a 3/8, half, and a 5/8 circle, reflecting really the growing anatomical precision required of the surgical needle and development of surgical techniques. Lister actually enabled this all to be sterilized. The invention of the atraumatic or swage needle was really in the 1800s. This reduced the eye and embedded the thread literally in the end of the needle. And instead of going through a hole, suture material was directly attached to the needle, creating a smooth, single-stranded passage through the tissue. And this is really down to a George Fowley Merson, who was working in Edinburgh between 1866 and 1859, and he came up with catgut as well as the suede suture, for which he was honored by giving a fellowship of the college. He was the president of the Newcastle upon Tyne Chemists Association as well. They started their suture business, which caught the eye of Johnson & Johnson, and they were bought out. And hence, we got Mersilk, because Merson insisted Mer was stayed in the name. And that's how Ethicon started. So moving from an eyed needle to a swaged needle, from a simple factory in Edinburgh, and we saw the birth of Ethicon atraumatic needles. And for this, in 1977, Merson was elected Fellow with the Royal Society of Edinburgh. Johnson & Johnson have expanded tremendously since then. They've introduced sterilization by radiation, and the company continues to combine technology and sutures and radiation that has enabled them to be at the forefront of suture material. Many other companies have joined in since, but the standardization and the marking of sutures, as we will discuss, has meant that all manufacturers stay to a certain shape and size that can be recognized and therefore industrially produced. So what's happened over the 20th century is, since we've got specialization, needles have been engineered with distinct cross sections, tapering, cutting, reverse cutting, depending on the tissues. And this has all been done to think about the tissue cut during the incision or during the rotation of the needle, but like the Boschy on my katana. Stainless steel has improved resistance. Now we've got different alloys, where machinery and alloys has enabled the grinding of tips into further shapes and smaller, leading to cardiovascular, microsurgery, and ophthalmic advances with smaller and finer needles for finer tissues. And the needle really is designed to carry the thread. And to date, most of the needles have been bigger than the diameter of the thread that was being used. However, Ethicon have now come up with a process of embedding the needle in a fine needle, such that there's no difference in diameter at all. So today's needles are highly engineered with specific geometry, specific metallurgy, and specific treatments tailored to the tissue type and operative context, including silicone coatings to reduce the drag, the body profile, and needle curvature, with all enabling, a bit like my katana, improved and predictable handling. What I'm a little bit alarmed about is that the curvatures have described the use for rotation of the wrist, but as we've explained before, with flexion, extension, abduction, and abduction, there's no rotation at the wrist, but circumduction. However, there is one reference to the fact we do rotate around pronation, supination. So what began as sharp and bone fragment has evolved into a precision instrument, a bit like the katana, at the interface of craftsmanship, biomaterial science, and a surgical art. A small tool that embodies the long art of surgical progress. So with that in mind, let's just go over and talk about some of the principles involved. And we're going to use some diagrams. So first of all, just to point out this curve, I've got a straight needle in this cup and I can't move it from side to side. No good. But as soon as I make my needle curved, as I've got here, I can now move that curve and needle around the full circumference of this cup. And indeed, all needles are made on a circumference. Now, to understand the anatomy of the needle, we need to understand that although it's made on a circumference, the length or chord in blue here is the length of the needle. And that is always put on the packet as the length. There are two no-go areas in looking at needles. Just turn it around. One is this area, is the tip. And the ratio of the body to the tip is 12:1. And it means that in the manufacturing process, the milling and refinement of the tip could take up to 1/3 of its needle. At this end is the swage, and I've represented it here as a thicker part of the needle with the suture embedded, as compared to traumatic needles, which had the eye and had to be hand thread. The body of the needle is this area between these two no-go areas. And for people to say you've got to pick it up 1/3, 2/3, or 2/3, 1/3, is actually wrong. And as I'll explain as we go along, because this is the functional pickup area of the body of the needle, and it depends on what you're doing. It all depends on the ability to rotate the needle. So let's dismiss the swage for a moment, and I hope you understand we don't pick it up there. You can easily pull the thread out. It is literally just glued in, and that is a laser precision hole. You do not grab the needle there. You can see that the thickness of the needle at the swage is bigger than the body, but modern needles have changed that, and eye needles are even thicker still. So if we say that the needle is made on a curve, and the curve lengths are determined mathematically, and I still can't work out why it is a quarter, 3/8, half, and 5/8. But where you pick the needle up is really dependent on its ability to be 90 degrees to the tissue. So a quarter needle is quite easy to orientate 90 degrees, if that's the tissue, 90 degrees to the tissue there. But if it's a 3/8 needle, one has to do a little bit of rotation, and if I hold it on halfway, that point is pointing into the tissue, and that is relatively easy. But if I put, this is a half needle, there you go, there's a half curve, I have to be able to pronate and supinate to be able to get that point into the tissue. And I'd hold it halfway. If I'm holding it back here, I'll take it too far. And if I'm holding it here, it'll be off as well. So I'm holding it in the middle. If I look at a 5/8 needle, if I hold it on the halfway and rotate the needle back, I cannot get this 90 degrees into the tissue, and therefore I have to hold it closer to the point. Therefore, the pickup changes depending on the curve of the needle and what you're wanting to stitch. Suffice to say that if you're stitching something solid, you're wanting to come in perfectly 90 degrees to that solid tissue and almost squeeze the tissue, if that's the tissue, my thumb, squeeze the tissue between your needle driver and your forceps on the other side, pressing it together at 90 degrees, and therefore you'd hold the needle much closer to the tip. So the pickup on the body is actually very variable, depending on the function. The body itself although we think the needle is round, the body itself is not. The body is slightly cuboidal. So what I want you to do is on your needle holder, just gently hold the needle as we've described before and move it from side to side. And you'll see and feel that it flips into place. It flips into place because the square edges of the needle driver are now becoming applied to the flat surfaces of the needle. And as that flipping into place and being able to feel that flip, see that? I'll move that out of the way so you can have a look, and I'll focus further down on the needle itself. I'll flip it into place. I can actually feel that literally flip into place, and therefore I can pick up the needle easily. So that's the swage, that is the body, and that is the rotation. But the rotation also depends, as we said before, that the rotation of the lower arm is pronation and supination. So there you go, supination, pronation, supination, pronation, supination. And you'll find that some people have got a limited pronation and supination, and that will also dictate where you pick the needle up on the body. So let's focus on the tips. Now, the needle tip is the functional spearhead of the surgical needle. It really determines how the needle enters the tissue and how much force is required, how cleanly the fibers are separated and cut, and ultimately how much trauma is produced. So while the body and the curve of the needle guide its path, it's actually the tip and the geometry that defines its interaction with the tissue architecture, as the Kasaki and the Boshi of my katana demonstrated. So first of all, one has a taper point. And the taper point, if that is an unmilled point, the taper point is milled to a sharp point. Without that point there, you would actually say that is a blunt or round bodied needle, and you sharpen it to a point, and there you've got a taper point. And the taper point needle is a sharp tip that gradually bends into the round body of the shaft. So rather than cutting, it actually dilating the tissues atraumatically as it passes through, so it's squeezing through the tissues. And it's ideal, therefore, for delicate, easily penetrable tissues such as bowel, muscle, peritoneum, blood vessels. And because it's spreading as it's going through, it minimizes trauma and supports watertight closures, particularly in vascular anastomosis. The cutting needle here is depicted by a triangle. That is the cutting edge, which is on the inside of the needle, that is cutting there, and that's cutting there. You rarely see traditional cutting needles nowadays. I see them on sternal wires, but there's a triangular cross-section with cutting edges 1, 2, and 3, and it slices through dense fibrous tissues such as skin. Traditional cutting needles place the cutting on the inner curvature, which predisposes to a cutout if tension. So that's on the inner curvature. And it also runs the risk of cutting the suture itself. So therefore, they reverse this, turn this and put the cutting on the outside of the needle. And this is a modification. And it moves the third cutting edge, which is this edge here, it moves it from the inside to the outside of the needle. And in doing so, it increases the strength and reduces the risk of the suture pull-through, and is now made as the preferred needle for skin closure and many other disciplines. The blunt needle itself is round and non-cutting, and they're used in friable tissues and solid organs like liver or kidney, and in obstetrics to reduce glove perforation risks. So again, a bit like the taper point, they gently separate the tissues. A modification of that is the spatula cut. And if you see the spatula cut, there's only cutting now in two directions. It is laterally. And this is for separating layers. You don't want to cut that way, and you don't want to cut that way. The spatula cut is typically found in ophthalmic surgery as you're doing layers of the eye. But as we've got better and better, what has happened with the development of the needle is we've been able to not only cut in triangles, you'll see that you've got different curves like that. And having got a different curve like that, we can now put different cuts on the needle itself. Or that can now include that. So these basic combinations have got more sophisticated with the ability for modern instrumentation to precision grind these tips. So the sharpness really depends on the tip angle, the edge geometry, the surface polishing, and this coating. And the central element to needles is designed to respect the tip tissues. The taper tip, coming back to this, in essence, there you go, taper tip preserves structure. The cutting tips now overcome resistance, and the blunt tips protects fragile planes. Thus, the geometry of the tip is not merely a mechanical feature. It reflects the surgeon's intent and understanding of the biological behavior of the tissue being repaired. So the needle size, this size needle refers to the thickness and the length. Now, the needle diameter is the gauge thickness, and the needle length from there to there is measured in millimeters, and the needle curvature, as we've demonstrated, is measured according to a quarter, 3/5, half, and 5/8. And the needle size corresponds really to the size of the suture that you're wanting to take through. And that depends on what you need the suture to do. How long is the tissue going to take to heal? And therefore, when is the maximal tensile strength of the tissue realized? So higher numbers with more zeros, i.e. 10 to 0, represent extremely fine. Lower numbers from 2, 0, 0, 1 are thicker, and numbers without any zeros are very thick indeed. So, for examples, we will show you some. Here we go, is a look at it carefully. We have an 8.0. It is 6.5 millimeters, and now we know that is a round-bodied but also tapered. So it's still round, but this is good for microsurgery and microvascular surgery. We have 6.0s and 4.0s. Here we have got a 4.0. This is 22 millimeters. Note that we've got a reverse cutting there. It's a triangle within a circle. And this is good for small vessels, skin, and tissues. We have a 2.0. here, 2O, 40 millimeters, reverse cutting. That's the length, the cord length, and that is good for general soft tissues. Okay. As we see a variation on the triangle there, it is curved. So this is this milling you see here. As with this 3O, 26 millimeters, reverse cutting, cut in that form. These heavier needles, 2O or 2 and above, are really for abdominal wall and orthopedic surgery. Here we have another milling. This is a 16 millimeter. And note this milling now is a fine version of tapering, indicating that the cutting of this point is like that, a Mercedes-Benz sign, and is not quite to the edges. And this reflects the ability of the needle to pierce and cut through tissues. So the needle diameter must be proportionate to the size of the suture. If you have too large a needle, it causes unnecessary trauma, and too small, it risks bending or breaking. The length, as we see here, 16 millimeters or 26 millimeters, is selected to the depth of the wound, tissue thickness, accessibility, and space constraints. So you can imagine in cardiac microsurgery here, joining small nerves together, or 7O here, commonly used, tapered point, 9 millimeters, cardiac surgery. And then we've got the bigger sutures for cutting, and this is 25 millimeters for skin and superficial closure. So the curvature of the needle, as I've demonstrated, the quarter circle there is really for surface work, is for easy access. The 3/8 needle here is most common in general surgery, and this reflects the ease of rotation and completeness of the circle. The half circle is for confined spaces, and the 5/8 circle is for deep and narrow cavities, particularly the oral cavity or down in the pelvis. So the ideal needle selection is the ideal needle is just large enough to carry the suture. It matches the tissue resistance and allows smooth rotation without excessive force. And they actually say wrist rotation, but this is not rotation, it is gaffing. So as we can see on this multitude of sutures, and do pick them up, there's a standard way of representing them. The length, the cut, and the gauge 3/0. And all the manufacturers across the board. That's B. Braun, that's Ethicon. I have got some Medtronic sutures as well, but the whole range of manufacturers all vying for your business and attention. So the needle you use is the smallest needle and the smallest thread that will accomplish the task. Too small, tissue trauma. Too large, tissue trauma. Too small, technical failure, and is not going to hold it together. Before we had the standardization of the curve, we had unpredictable arcs and inconsistent mechanics and wrist movement. To actually learn how to use the needle and use the rotation properly is going to be the very basis of our next lecture, which is going to divide the needle function into how to pick it up properly, how to get the needle moving for you, and that is dependent on you understanding that it has got a square surface at its body, as you can see on this needle. And that enables it to flip into place. The fact we've now got standardization enables us to consider formal education and training. The banana is on a curve itself, isn't it? And that is probably a quarter length needle. And I don't have to rotate it far to point into the table. But what I'm bringing this to your attention now is this point and understanding the point in pickup. And this is my closing message for this deconstruction. So I want you not only to take a needle, hold it in a needle holder, understand that it flips into place on the body, put it at the tip, and try this. If your needle's too far back and you rotate it back, you can see my needle is not reaching that banana at 90 degrees. I'll bring it over here. So there you go. That's not hitting the banana at 90 degrees. And if I take it into the surface, you will perceive that I can feel that my needle is actually gouging the surface of the banana. And it actually feels hard, and there's a lot of resistance because I'm going in at an obtuse angle. Okay. However, if I hold the needle closer to the point and rotate back, I can now feel the needle pinprick this banana. And I'd ask you to do it yourself before next week and feel the difference. As we let this banana develop, and I'll focus down on it, you will see the gouging here and the pinpricking here. It is obvious to feel and it's obvious to see. Gouging, pinpricking. Now, you may or may not have stitched a button to the shirt. And if you don't take a button perpendicularly to the shirt through the warp and weft of the material, you'll find the needle doesn't go straight through. It is hard. In understanding the anatomy of the needle, you want needle to pass cleanly through the tissue, letting the tip do the work. As in my katana, the boshi is slicing with very little effort. And that is because I'm using the curve of my katana, as you need to learn how to use the curve and appreciate the point. And you'll see now the clear difference between not 90 degrees and 90 degrees to the tissue. This is actually evident also looking at the Chinese diving team enter the water. When they enter the water, and a 17-year-old has just left a 17-meter platform and hit the water with no splash whatsoever. Yes, they are trained to put their hands in front of them to create a space into which to dive, but to see somebody hit the water perfectly at 90 degrees with no splash is quite something. And the Chinese have made that an art and lead the world in diving in this regard. So we have covered the size of the needle, the curvature of the needle, the cord length, the no-go areas, which is the swage and the tip. The swage, traditionally with the eye, was called a traumatic needle. So we've got the length of the needle, the curve of the needle, the no-go area, which is the swage, which used to be the thickest part of the needle, but certainly thinner than a traumatic needle with an eye. And we have a wonderfully milled tip that actually delivers the needle through the tissue. So what we've got from here is we've moved from a needle that had artisan variability to something now with geometrical predictability, from hand forged and made tools of bronze and iron in the Roman days to engineered precision. And now, knowing the anatomy of the needle, we can start to learn to use the anatomy, understand how to make it easy to use with atraumatic to the tissue, and therefore we can now introduce reproducible training systems. And there you have it. The anatomy of the needle parallels the katana. And unless you understand how the needle is made and its function, you will not understand how to use it properly. I reflect on one of the training courses I did in cardiac surgery, the power aortic course, that had national and international acclaim. And one of my trainers on there, Martin, who used to be my trainee, he said, have you ever looked at the needle you were given to use on a tissue valve, on the cuff on a valve? And I said, no, I hadn't, because I was just using the needle and asked the staff for the needle on to a tight rod and didn't actually look at the needle itself. He said, well, you need to, because the manufacturers of these heart valves expressly say, do not use cutting needles on their valves. And I suddenly had an aha moment and thought, in all my years of cardiac surgery, I never questioned what the tip of the needle was actually doing and what damage it could possibly do, not only to the tissue itself, but to the prosthetic heart valve. And that's why I think it's important that we labor this point this evening on valve use and valve manufacture. There you go. The last valve suture I've got here is a very large needle, and it has got a wonderful milled sort of Mercedes bend cutting point. And with that, I'd like to ask my fellow colleagues to join in the conversation and to offer their insights to needle choice, needle function, and understanding, and any stories they have about needles. The last important thing, as we do in the Black Belt Academy, when we hand out needles for practice and we in the dojo, the most important thing is it's surgeon's responsibility to look after the needle. So in the gradings on Saturday, I came across a couple of needles that had been left on the table and a couple of blades left on the table. That is not acceptable. You need to take responsibility for your needles. So needle coming in, needle coming out, you need to make a mental note of it, because the needles are counted on the count board. They're counted by the nurses preoperatively, and they're counted by the nurses postoperatively. That count needs to match the count before and after and on the board. But you, as a surgeon, are responsible. Now, what happens if you close with a needle? Well, I was assisting a senior registrar of cardiac surgery who put pacing wires on the heart. And the pacing wire came with a swaged proline on the end that was bent a bit like a corkscrew, so you could take it through the myocardium, cut the needle off, and the active end of the pacing wire would sit directly on the myocardium. But he failed to actually cut the end off, and that was the size of the needle. And he started closing. And we said, what about the needle? Oh, no, it's not a problem. So the anesthetist also said, what about the needle? He said, no, not a problem. And we were almost close to the skin. And he came back and he said, no, I have to open to take it out just as well. If you lose a needle and you can't find it on the floor or in a swab, etc., you can't carry on with an operation or close. You have to do an X-ray to look for it. Now, the difficulty is, the smaller the needle, the more difficult it is to find. And certainly something less than a 5/0 would be extremely difficult to find. And that's why it's even more important that you pass your needles out on the needle holder safely to the nurse, preferably in a kidney dish. But if you pass it back, pass it handle first. But make sure that the count going in and the count going out is the same. And if it's not the same, it's your responsibility to find that needle. They need to be disposed of safely as well. And they're usually put on adhesive pads where they can count them accurately. And those adhesive pads are then closed and disposed of in shelf boxes. Your addition, Sensei Caddy, on needles.
Thank you, David. As they say, every day is a school day, and I learned so much today, so thank you. What you were describing there is systems thinking, so that the system has been set up to prevent loss of needles, to ensure that the needle is accounted for throughout the whole process. And so it brings in the not side of the surgery, non-technical skills. It's about decision making. What needle are you going to use and why? And you need to think about that way in advance of the operation you're about to do. Now, your theatre team will know in advance what sort of sutures you're going to use or may need to use, but it's your responsibility to ensure that those sutures are available within the system, rather than saying, well, no, we don't have any Prolene. You can develop the adaptability to use anything you want, but if you're going to use Prolene, think, why am I using this suture? What are the specifics of this suture that I require in this operation? And these things, once again, they're often taken for granted, but you walk up to the table and you know exactly what you want, but the rest of the system is not aware of that.
Well, there's a little story there.
I'm sure there is.
And the story is that I'd done one emergency in the morning, coronary artery bypass grafts on a 54-year-old, and the fact that we had to prioritize, and that's a different thing, patients. He came first before a 74-year-old lady who was diabetic with triple vessel disease. And all the sutures, the 6-0 Prolenes, but I used 7-0 VisiBlack, which is an Ethicon special suture, fantastic for internal mammary artery and Lima to LAD. And the VisiBlack also is very hardened alloy that enables you to go through calcified vessels. So after the first operation, I was then informed that theatres had run out of 7-0 VisiBlack sutures. And I had a word with the theatre team and said, well, I know from the angiogram, the 74-year-old has got diabetic, has got very calcified vessels. And I'm loath to actually do an operation not having a needle that could penetrate calcified coronary vessels. And since she is relatively stable, I suggest that we urgently get some 7-0s and we postpone the operation. Everybody agreed, and there was embarrassment that there were no 7-0s in there. That's a different systems thing as far as procurement and who was responsible. The long and short of it is that I understood that the medical director 4 days later was going around holding a different 7-0, not a VisiBlack, saying, I'm not sure what planet he's on, I don't see the difference. Yes, he was a vascular surgeon, but he was not a cardiac surgeon, and he had never stitched a calcified 2mm coronary vessel. And if he had, he might have actually understood the need for a proper needle. And that's it. If you don't have the right material to do the right job, you shouldn't be doing the incision in the first place, because once you start, you can't stop. It becomes your responsibility. And if you don't have to, and you don't have the equipment, stop. And in this occasion, I stopped because we didn't have the suture. I thought it was very reasonable, but some people, and so did most of the theatres, but some people did not. That's their problem. The patient underwent an uneventful operation the next day, and indeed I needed VisiBlack on all the vessels. Usually it's reserved just for Lima to LAD.
It's a bit like Tiger Woods turning up to run on the course, and you're handing him your set of clubs and saying, use mine. They're great.
Well, there's a
They
story
may
there
be great
too.
for you.
Yes. Yeah, but that's exactly it. And the end user, the surgeon who is actually trained. The other thing is that I I knew the Ethicon rep, and he came in, and I said to him, "This is a 7.0 needle, so smaller, that's one up from that." And I said to him, "You've changed the needle." And he said, "No, we haven't." I said, "I'm sorry, but you have changed the needle." "No, we haven't." I said, "Well, okay, I find that very surprising." And then a few months later, he came back and he humbly apologized because, yes, they had changed the cut of the needle, but they hadn't informed the marketing team. But I'd felt the difference, even on a 7.0 needle.
So once again, our students will come across this during their careers, is they're asked to use whatever's available. It's all about procurement and the procurement process. How do people choose the sutures, the gloves, the instruments in your sphere of influence? And you, as the leader of that team, need to be aware of what's possible, what's not possible, and you then need to take the impossible and make it possible if it's appropriate.
Indeed. And you can't have a whole lot of different types.
Yeah.
You have to work within reason. And unless it's really specialized and you're the only person on the planet doing it, uh, it's best to use standardized sutures. But 7.0 VisiBlacks are standardized sutures and recognized. Ethicon did invite me to test out their kryptonite needle, which I think has become Everpoint, which is a new alloy. But with the VisiBlacks also, I noted sometimes that the one VisiBlack was better at penetrating the tissue than the other VisiBlack. And then I found out they had two manufacturing plants, one in Germany and one in Michigan in the United States. And just as the katana with the alloy process and quenching, I think there was a difference in the temperatures of quenching that made the one needle softer than the other. Now, I couldn't pinpoint which was Michigan and which was Germany, but I did feel a difference between the two VisiBlacks. And it takes me back to the manufacturing of a katana.
So these are the nuances of behind the anatomy of the needle. And
Indeed.
most people don't know what they don't know
Mm.
until they study the anatomy of the needle, just like we study the anatomy of the human body in order to be able to operate. This is part of our sphere of influence that we need to understand. We don't need to understand everything about it, but we need to have the rudiments and how to communicate that to our students. So you're passing on lots of knowledge here. So next time you meet your students, you can ask them, tell me about the anatomy of the needle, and get
Indeed.
them to tell you exactly.
Indeed. Or you can also make a collection of different needles and see how many different circles and points you got in there. And when you look at them, some of them are really quite fantastic. And to get that level of precision and machinery on the tip of something that is the size of your eyelash, you just think, wow, that is manufacturing at its best. And then to put a thread in the end, using a laser to make the hole to put a thread in, gosh, is mind-blowing.
So when I was a medical student, I trained in Edinburgh, which is where Ethicon had its factory. And we as medical students went out there to see how the sutures were made and how they were swaged onto the needles. And once again, it's an amazing process. And if you ever have the opportunity to go and watch it, do. Because
What I like about take your opportunities to go and see how blades are made, how instruments are made, how sutures are made. But there's one important element of this manufacturing process that you have to understand that really puts quality control in healthcare to shame. Because each of these sutures, as you've got there, has got a QR code. That QR code will tell you the date, the time, the lathe, the machine, and the manufacturing. And those, a bit like valves, have to be available 24/7 should there be any problem anywhere in the world and a malfunction. Compare that to the availability of hospital beds, all on a single QR code. You could probably name the person who's on the machine at that time and how many batches of oil had been through the machine, how often the machine itself had been serviced and its service history, when it was bought, when it was serviced, etc. All on that. And you look at that and compare that quality control, which in industry is down to 6 sigma. That's 6 standard deviations from the mean. And
That's about understanding systems thinking.
and understanding quality control and systems thinking as well. And the instruments we use and we take for granted, the skill, the governance, the attention to detail is second to none. And I think to be honest, I think there's a certain arrogance amongst the people who actually use this in taking it for granted. And I'm just saying to all trainees, in using your instruments and your sutures and things, do think about the person who actually made it and the process. Because quite frankly, it's mind-boggling. And if you get an opportunity to see this being made, seize it, because your life and thinking will change thereafter.
Well, as I said, I had the opportunity to see these threads being put onto the needles, and it is mind-numbingly boring work. But these girls, women, whoever, were passionate about it. And it had been in the family for years and generations. That what they did. They were incredibly well paid. They were looked after. They were nurtured. They were valued in what they were doing. So it's all, once again, it comes back to understanding systems thinking and working with people. What are the values of your organization? What are we trying to achieve here? And it's underpinning all of this is quality. If you get the quality right, everything else falls into place.
Exactly.
Yeah.
It's quality. And it comes also, therefore, to quality training as well. And I like to think that in the Black Belt Academy that we're drip feeding this to you, and hopefully you have a better appreciation of how to use instruments, what they're made for, and appreciation. The symbolic part of the Black Belt Academy is really become banana. And I just wanted to show you the difference there, which has now become very visible between the pinprick and gouging. There you go. If you don't use your needle properly, that's what you'll be doing. And we'll be visiting this next week. But isn't that a graphical representation?
I think what's important to point out as well is that your needle is a surgical instrument.
Yes.
You explained that, but as the surgeon, you need to respect your instruments and in particular the needle every time you pick it up. As you mount it, look at the point of the needle. If it's bent or warped, you need to hand it back and say, can I have a new suture? And once again, the staff in theatre will either respect you for your stance on that or feel that you're being too pernickety, too high and mighty. But it's all about setting standards. And if you set your standard up there, you're not going to accept down here.
Indeed. But in that regard is how you communicate it and bring everybody with you. And that's part of the non-operative technical skills of surgery.
So
any questions?
Is Celia around? Does she want to join us?
I don't know if Prof. Celia is with us. I would like anybody watching, if they've got any comments, just looking at Shavita, who is graded on Saturday, was with us. And Adesh is with us as well. I don't know if you want to add any comments on your experiences as trainees, Shavita and
Well,
Adesh.
it would be good to put Ardesh on the screen.
If you
What-
can.
If you can, yeah.
There you go. Welcome,
Alright. Hello,
Susan.
Prof.
How are you?
Yeah, I'm fine.
Welcome.
Hello, Prof. Caddy. Honestly, I don't think I have that much to contribute. I've only used one type of needle, which is the curved needle. The
Yeah, but
Prodine, I think it's the
usually
3O.
what we're doing in practice actually, Adesh, is with the linear stitching, we're using an eyed traumatic needle. So that is actually making you think even harder about the rotation because the eye is so much bigger than the body. So we're using traumatic needles in this. One, because they are cheap and cheerful, you can buy them online. And I think it's unreasonable to be opening new packets of sutures all the time. And you certainly can't recycle used needles in theatre. However, there are often unused needles in theatre that you can borrow. But online, you can buy half circle eye needles, but they really do test your skill in rotation, don't they, Adesh?
Yeah, they do.
So once again, talking about needles and the anatomy of the needle. So David showed at the beginning what we call a Keith needle or a straight needle. Now, some surgeons swear by that, and that's the only way that they will close a wound. So if you learn to use a straight needle to close a wound, then you will think that that's the way it's always been done. So you need to expose yourself to lots of different systems, find out what works for you, accept it and move on, or reject it and try something different. So we're trying to facilitate your training. So we're giving you the tools. As David was coming home this afternoon, I asked him if he had an eyed needle to demonstrate with this evening,
left it in CSU.
but he'd left it at work. So he and I know the difference between the two and the impact that that will have on the quality of your end result.
But even
But
so,
you're not
I must
aware of it.
Adesh on his technical skills with an eyed needle.
Yeah.
He's going in and out very well on the bananas. The one other interesting needle one. I worked with a surgeon actually in Banbury in Oxford as a registrar of general surgery, and David Budd, who was an excellent surgeon, he preferred stitching bowel with handheld needles rather than instruments. So he was using quite often these big handheld curved needles as well, and very proficient at it as well. But it was interesting to see, as you say, different styles, different needles, and different eras. So every person you work for has got a reason for using that. Just inquire and ask. The best thing you can do in training is ask why or explain.
In many ways, it's a bit like, you have trained in one style of karate and Iaido,
Yeah,
but there are lots of different martial arts
true.
and there are lots of different philosophies behind it. But you need to find out what works, what's core knowledge, and what can you use moving forward in your career.
They're all originated though from one form.
Yeah.
They all derived from one form. So maybe the Black Belt Academy will be the original derivative of surgical training based on martial arts. Put the
We
plug
can
in.
but hope.
Good.
We'll keep trying.
And thank you, Sensei Creddy. I must thank Dr. Aprajita in New Delhi for the production. And thank you, everybody, for joining us. And our regular viewer, Dr. John Rudd, who's kindly, and I have not received yet, sent me some fishing line from the UK because they're having difficulty finding it here. And he's kindly posted some fishing line. So thank you very, very much, John, for doing that. And I look forward to receiving it before our next knot tying exercise. Thank you for joining us. We'll see you next week. We wish you well. And it's entering a holiday season as everybody's working up for Chinese New Year, which is the 17th and 18th. It's Tuesday and Wednesday next week, but we will be live on Black Belt Academy. And of course, on Wednesday, Ramadan starts as well. So with the festivities coming up, taking in Malaysia and around the globe, we wish you well, and we'll repeat that again next week. Thank you very much. Adesh, thank you. Chris, thank you.
Thank you, Prof.